everyone. Next, we'll hear from Kathryn Kietzman, who is the Director of Health Policy Programs and Senior Research Scientist at the UCLA Health Policy Research and Associate Researcher of Community Health Sciences.
Good morning. Thank you for the introduction. Great to be here. I'm fortunate to have a researcher appointment at the School of Public Health and Community Health Sciences, but also to work at the Center for Health Policy Research. I don't always get up to this part of campus because my office is there, but then nobody's in their offices anymore, are we? I don't know. So I'm going to zoom out a bit, and what I'd like to talk about here is not so much about a specific research topic or area in health equity, but to talk about a broader effort to move from an understanding of health disparities to the opportunity to advance health equity in our communities. So when I assumed the role of director of the Health Equity Program at the Center for Health Policy Research about a year and a half ago, we made a very intentional decision to change the name from health disparities to health equity. And we made this decision because we wanted the name to reflect a more actionable and aspirational program, where in addition to generating evidence, documenting existing disparities in health and healthcare outcomes, we also wanted to contribute to the process of identifying and advancing solutions to moving data forward to achieve health equity. As many of you may know, the Center for Health Policy Research was founded in 1994 by the late Dr. E.R. Rick Brown, and he had a long-range vision and commitment, passionate commitment to the democratization of data. Almost 30 years later, the center works to continue and expand his legacy and this commitment, now under the inspirational leadership of Dr. Inez Ponce. So the democratization of data, I always trip on that word, comes in many forms, but at its core, it's designed to put data in the hands of those who most need it and to accelerate the translation of data to action. So with that as a backdrop, over the next 5 or 6 minutes, is that what I have left? I would like to think through with you some of the essential ingredients of a program to advance health equity, and to illustrate these components with some current examples from our work at the Center for Health Policy Research. So we can certainly start with the need for data, but we need to think carefully about what types of data we need and who needs to be at the data table. In other words, we need to be inclusive in all phases of the research process. We also need to ensure that the data that we gather and analyze is representative and easy to access. Once analyzed, an additional step is needed. The findings then need to be translated to policy and practice. And finally, in order for our efforts to be sustainable, we must support the next generation of health equity champions. In recent years, there's growing recognition and support for opening up the research arena to be more inclusive. Being more inclusive means ensuring that the voices of those being studied are part of the research process itself. It means engaging with and learning from individuals to understand what matters to them, what issues are the highest priority within their communities, and to involve diverse stakeholders in both the identification of the problem and the potential solutions. It also means collaborating to develop and implement culturally appropriate and sensitive approaches to gathering, analyzing, interpreting, and disseminating information. In addition to the what information we need to gather, we also need to think carefully about how we should collect it, who should collect it, and what methods should be used. A more equitable research enterprise is also one that is expansive, inviting representation that spans academia and community and reaches across disciplines, professions, and generational divides. And the research projects developed should reach a broad and diverse audience. In addition to being inclusive, we need to ensure that the data is representative. This means stepping back to consider where are the knowledge gaps, whose story is not being told, what are the consequences of these gaps. Data need to effectively represent the population groups for which it bases its claims. These data are used to identify needs, to make decisions about what interventions are appropriate, what programs are needed, and how resources are allocated. Gaps in representative data perpetuate health inequities. One example is evidenced by the experience of the Native Hawaiian and Pacific Islander community. For decades, the health disparities they experience have been hidden due to a lack of disaggregated data. As members of the NHPI community have most typically been grouped with other racial and ethnic groups, effectively masking their unique experiences and needs. The NHPI Data Policy Lab at the Center for Health Policy Research is working to address these gaps. The lab has launched 4 data dashboards and a data policy platform focused on providing accessible tools on the health and health needs of the NHPI community. It is a powerful resource for change agents, policymakers, community activists, and data-driven institutions who are working together to improve data systems and processes to better reflect NHPI communities' challenges and strengths and address their needs. Other examples of ensuring that data is representative are provided by the California Health Interview Survey, which we call CHIS. And this is the largest state-level population health survey in the US. It's a leader in the disaggregation of data through its representation of multiple racial, ethnic, linguistic, sexual orientation, and gender identity groups. In addition to the ongoing survey, which collects data from about 20,000 California households annually, CHIS also supports several follow-on studies that can allow us to take a closer look at the health concerns of specific subgroup populations. For example, these fact sheets report findings from a 5-year NIMHD study on immigrant health, which specifically investigated the exclusion experiences and perceptions of Latinx and Asian immigrants in California, and how multiple institutional sectors and policies intersect to affect their access to health care. Another CHIS follow-on study, funded by California's Department of Healthcare Services, is investigating the long-term service and support needs of older adults and people with disabilities in California. And these data are currently being used to inform the state's 10-year master plan for aging by providing indicators to populate their data dashboard on aging, which is tracking progress towards achieving its goals for improving the health and well-being of older Californians and people with disabilities. To achieve health equity, we must also make data easy to access. Examples include the visualization of data through data dashboards and infographics like those displayed here, which shorten and simplify the presentation of research findings for a general audience. We also support access to CHIS data through data user trainings that introduce community members and non-researchers to user-friendly data tools like Ask CHIS and Ask CHIS Neighborhood Edition. A fourth element essential to achieving health equity is the translation of research to policy and practice. It is the ongoing engagement with the community, the communication of research findings to a broader audience, and the relationships that are developed along the way that are needed to make data actionable. And this step goes beyond inviting community members to join our research enterprise and be part of our advisory boards. It means we also need to go out and truly engage with the community, serve on their boards, follow their leadership, and contribute to the goals they have for the community. Finally, arguably most importantly, we need to support the next generation of health equity researchers and champions. Last year, we launched the Health Equity Challenge with the support of Molina Cares, and this year, with additional support from the California Healthcare Foundation, we have currently a cohort of 14 UCLA graduate students from public health, social welfare, public policy, medicine, and education. And the goal of the program is to support these graduate students who are committed to finding practical, community-based solutions to address long-standing and persistent health disparities. Over a 15-week period, the students are paired with an academic or community mentor to help them develop their intervention or program and to turn their idea into a full proposal. The students also identify a partner and partner with a CBO that can implement their idea. The final proposals are reviewed by an independent review committee, and up to 4 community-based organizations are awarded $50,000 to implement the winning students' ideas. You may recognize some of the students that are up there, if you can see them. So the passion, commitment, and innovation that these students are bringing to the table really promises hope for our future, and all of us working together to achieve health equity. Thank you so much.
Thank you, Dr. Kietzman.